Okay, so James, you ready to go?
I'm good.
Okay, so we'll go ahead and get started. Thanks everyone for joining us for this installment of the National Fellow Online Lecture Series. I'm Robbie Bowers with Emory Sports Medicine in Atlanta. I'll serve as a moderator for tonight. So before we get started, just want to plug the next lecture, which is going to be December 8th at 8:30. So next Wednesday, 8:30, same time, same day of the week. That'll be on dental injuries and facial fractures with James Toldy. Also want to plug our keynote lecture, which is going to be on December 15th at 8:30. So 2 weeks from tonight. With the role of the head team physician panel. And you see our speakers there, Carly Day, Ashwin Rao, Monica Rowe, Chad Holsopple, and Peter Bruckner. And then selfishly, I want to plug our overhead athlete panel, which is going to be January 19th with that Jason Zaremski and myself have put together, and that will be starting at 8 o'clock instead of 8:30, and it'll be 2 hours. So 5 speakers, 20 minutes each, and we have a good panel of speakers with myself and Dr. Zaremski, Kayla Holtz, Amy Liu, and Kevin Wilk, who's a very well-known physical therapist in the overhead athlete world. So with that said, tonight's lecture from Dr. James Robinson is going to be on ocular injuries. And before we get started, just a couple housekeeping things. Again, as we said throughout this is to serve as an adjunct to your individual programs, educational content. It's not supposed to take the place of it, to provide fellows with direct access to educational experience with a wide breadth of AMSSM members. And it's also to help with CAQ exam preparation as well. So everyone's devices will be muted. Your video will be off tonight. If you have any questions, put them into the chat function. And then at the end of the lecture, I'll ask Dr. Robinson the questions and we'll go from there. And then please complete the survey, and there'll be a link to that in the chat as well that Andy will put there. So with that said, our lecture tonight is on ocular injuries with our speaker is James Robinson from Hospital of Special Surgery in Brooklyn. Dr. Robertson did his residency in family medicine at St. Joseph's Regional Medical Center in South Bend, Indiana, and did his fellowship at ASMI in Birmingham. And now currently, obviously, is an attending at HSS and specifically in Brooklyn. So with that said, Dr. Robinson, please take it away.
Well, thank you very much. Let me see. I'm going to share my screen so I think everybody can see it well. So like Robbie said, we're going to talk about ocular injuries in sports. Obviously, there's lots of eye conditions that affect our athletes, and as team physicians, we need to know about all those, but it's a lot to cover in one lecture. So we're really going to focus on injuries. I have no relevant financial disclosures. I will say, if you tuned in to see gruesome pictures of eyes, you're in luck. There are a few. And if you're not if you don't like seeing those kind of pictures, don't worry, I didn't put some of the worst ones that I found on the internet. With that said, our objectives are going to be to briefly discuss the incident of ocular injuries in sports. We'll also review ocular anatomy, just to kind of a review from our gross anatomy. We'll talk about important history and physical exam findings that you need to go over with your athletes. We'll talk a little bit about the sideline bag and supplies you need to properly evaluate ocular injuries. Probably one of the most important things that we'll talk about is when to refer to ophthalmology and how urgently that needs to get done. And then we're going to spend the bulk of our time talking about common different ocular injuries and conditions, how you diagnose them, and then their treatment. Then we'll briefly discuss some return to play considerations, and at the end, kind of talk about eye injury prevention. So how do ocular injuries impact sports? So the answer is a lot. There are a lot of ocular injuries in sports. They're fairly common. So when you look at studies that look at all presenting ED, so not just sports, but just presentation in ED, ocular injuries represent about 37.6 per 10,000. So a pretty good amount. And unfortunately, sports are responsible for a third of all ocular injuries that lead to blindness. So it's not an uncommon phenomenon, and unfortunately, the results can be pretty catastrophic. Males are disproportionately affected, and in some studies have been shown to be responsible for as many as 81% of sports-related ocular trauma. Traumatic eye injuries are the leading cause of non-congenital blindness in those under 20. So again, this is a big problem. Some reports estimate that it totals about 100,000 physician visits per year and costs the medical system about $175 million. So your highest risk sports are your contact sports, or actually your combat sports. So boxing and MMA and wrestling, obviously those carry the greatest risk. Other high-risk sports include baseball and softball, basketball, which I cover, and one of the reasons that I had to become familiar with this, racquetball, lacrosse, and hockey. And then other sports that this can happen in, but not as high risk, are football, soccer, tennis, volleyball, fishing, and golf. So it can occur in most any sport. We will talk about in sports that have smaller diameter balls. So things like baseball, racquetball are actually ocular injuries are more common because of the size of the ball. So when we review ocular anatomy, so it's kind of important when you talk about the physics to remember that the eye is not a true sphere. So the diameter of the cornea is actually smaller than that of the sclera. So it's not a perfectly rounded sphere. And so when you look at the eye, you've got this lining on the outside of the cornea, and that connects to the sclera, which is the white part of the eye. And then you have three chambers in the eye. So the anterior chamber is made up of your cornea, then your anterior chamber of fluid, and then the iris and pupil. And then you have the posterior chamber, which is made up of your ciliary body and muscles and the lens. And then you have the posterior part of the eye, the vitreous cavity, which has the vitreous body with your vitreous humor, contains your retina, your optic nerve, and your fovea. Not shown in this picture is the conjunctiva or the conjunctiva, which is the thin lining. It starts on the lid of the eye and then comes around. Vascular supply to the eye is made by the ophthalmic artery, which is a branch of the internal carotid. So some things to look for when you're evaluating ocular injuries. So one of the first things you want to ask yourself is about history. So when you're looking at it, you want to know what's the mechanism of injury. Try to deduce the force, the direction of impact. Higher velocity injuries are more likely to cause ocular trauma, globe rupture, penetrating eye injuries. You also want to know about foreign bodies. So did they have on glasses that could break, or safety goggles that broke, things like that. You want to talk about symptoms. So things like foreign body sensation, which we'll talk about is common with corneal abrasions. One of the biggest things you want to know is about decreased visual acuity. So can they still see? Do they have good eyesight? If they do not, if they can't see, if their vision is compromised, then that's usually a sign that they need to go pretty urgently for evaluation. Double vision or diplopia, we'll talk about, can be a sign of certain conditions. Tearing or photophobia also can be benign, but it can also be a sign of kind of a more serious condition. And then, of course, flashing lights or halos, which, of course, we all know is, or can be signs of a retinal detachment, which is obviously pretty serious and pretty urgent to figure out and get them to the appropriate people. So on physical exam, obviously, you want to look for deformities, erythema, hematomas, kind of assess a general view of the eye before you start doing your full exam, before you start talking about putting anesthetic in there, because there are certain conditions that you definitely don't want to use topical anesthetics or fluorescein for. Testing for visual acuity, this can usually be done with a Snellen chart. You can get a pocket Snellen chart that they can hold at their side. You want to test for visual and confrontational fields, making sure they don't have any deficits in their vision. Look at extraocular movements. Look at pupillary response. So one of the things you're looking for with pupil response is a relative afferent pupillary defect. So basically, we all know that when you shine light in the eye, both pupils should react. And so if you shine a light in the eye and neither pupil reacts, then that's a sign of what's called a relative afferent pupillary defect, which means that the eye that you're shining light in, the optic nerve is not working, or the retina is detached. And so that is obviously a sign of a big problem. You also want to look with a light source, looking for blood in the anterior chamber. You want to look with an ophthalmoscope, looking for blood in the vitreous chamber. You want to examine the orbit for crepitus. So we're not going to spend too much time talking about orbital fractures, so that's probably going to be covered more next week. But obviously, those can occur with ocular injuries as well. And then we'll talk about a fluorescein dye test and how you use it and the best ways to go about that. So this little video here. So hopefully none of you experience this in your covering career. This actually is pretty rare. So when the eye actually leaves the socket, called a globe luxation. But the main point of kind of pointing out this video was to look at the mechanism of injury. So if you go back and look at the mechanism of injury here, it's relatively benign. So he kind of gets poked in the eye by another player going up for the rebound, but it's not a huge hit. It's not like a big punch or something like that. So, sometimes with these ocular injuries, it doesn't take much force to get a pretty severe injury. So if this happens to you and you're covering on the sidelines, so you never want to try to force the eyeball back in the socket. You want to just keep it moist and get them to the appropriate people, get them to an ophthalmologist who can reduce the eye. More commonly, what happens when people think that the eye has sublux out of the socket actually is what happens is the lid gets knocked behind the eye. So it gives the appearance that the eyeball's out of socket, but the eyeball's still in the socket. The lid is just gone behind the eye. So when we talk about our sideline bag, so what kind of tools do we need to evaluate for ocular injuries? So we talked about a Snellen eye chart. You can see it here. This little pocket card, it's a great little resource to kind of help test for visual acuity, because sometimes athletes will think that they're seeing just fine, but they're really not when they try to actually focus and on smaller objects. They're really not seeing well. An ophthalmoscope, like we talked about, that helps you visualize the posterior aspect of the eye, the retina, the vitreous humor. A pin light. So a pin light with this little blue filter on it kind of mimics a Woods lamp. And so it helps when you're looking for corneal abrasions and things like that. And you can find these are relatively easy, as most of us on the sidelines are not going to have access to a slit lamp. So in the picture here, you see the fluorescein dye. So to use this, you take some sterile saline or contact lens solution, you wet the fluorescein, and then you put it just under the lower lid, and then allow it to kind of get into the tears, and then you have the patient blink a few times, and so it coats the eye. Cotton swabs, we'll talk about removing foreign bodies and why cotton swabs are important. If you feel brave and you have a very steady hand, sometimes you can use a needle to help take out foreign bodies. Sterile saline or contact lens solution is really important to have in your sideline bound. And then a topical anesthetics such as tetracaine. It's very difficult with a lot of these injuries to evaluate them, because obviously the athlete's in distress, they're blinking a lot. It's really makes it very difficult to evaluate the injury. So once you've ruled out a globe rupture or a more serious injury, then putting a little tetracaine in there can help so that you can get a better exam. So what are some of the things that should prompt you to look for an urgent referral and get them in to see an ophthalmologist a little bit more quickly? So obviously we talked about loss of vision. So this is a big one. If they don't have good visual acuity, they can't see very well, then that can indicate a problem with the optic nerve, the retina. Definitely something that you want to get a further evaluation with. Pain with eye movements. So when we talk about pain with eye movements, that could indicate a hematoma around the eye. It could indicate a globe rupture, those kind of things. So that's something that you want to look for. Diplopia. So can anyone think of a reason why diplopia would be a reason that you want to get them in to see someone fairly urgently? You can unmute yourself if you have any idea. Especially this would be vertical diplopia. So when they look upwards, they have double vision.
You've got a trapped extraocular eye muscle and an orbital floor fracture.
Correct. So this is a trapped inferior rectus muscle that in an orbital floor fracture. So obviously you want to get those people to an ER to get a CT scan to look to evaluate that trauma. We already talked about light flashes or floaters are symptoms of a retinal detachment. Hyphema, which we'll talk about, which is blood in the anterior chamber. Obviously that indicates a problem. Halos around eye lights can be a sign of a more serious problem. Obviously, if you suspect a globe perforation, that's obviously a ophthalmologic emergency, and you need to get them in fairly quickly. Loss of visual fields. Photophobia. So photophobia is one of those symptoms that you can be found in very benign conditions, or it can be found in very serious conditions. And so sometimes, not all photophobia has to be referred, but you've got to be able to tease that out. So proptosis, which is where the eye sits forward, or inoptosis, where the eye sits back. Obviously, proptosis can indicate blood behind the eye, which we'll talk about why that's a problem. Inophthalmosis can be caused by an orbital fracture. An irregular shaped pupil, that's a globe rupture, usually. Embedded foreign body that you can't get out. So if you're not able to remove the foreign body, obviously people need to go somewhere. We'll talk about lid lacerations and ones you should try to repair and ones that you should not try to repair. And then a 360-degree subconjunctival hemorrhage. So on this picture here on the right, you see this is just a normal subconjunctival hemorrhage. But on the left, you see how it kind of is all around the sclera and the conjunctiva. That is more concerning for a globe rupture and should be a sign that you need to get this person to further evaluation. Okay, so now we're going to talk about specific ocular conditions. So we'll start with one of the most common corneal abrasions. These are extremely common. You will see these in your coverage on the sidelines. You will probably, if you cover basketball, you will see them quite frequently. Usually these result from a finger to the eye. What they are is a defect in the corneal epithelial surface. They're usually traumatic, like that, usually caused by a foreign body hitting the eye, such as a finger, but they can occur spontaneously. So they occur spontaneously, have been reported in distance runners. So from dry eyes chronically. And then it can also occur in our college athletes because they tend to not clean their contacts or take them out. And so they can occur from those. So the symptoms are a foreign body sensation. So they feel like something's in their eye. Obviously, you should evaluate for a foreign body because these two can occur in conjunction. Photophobia is common with this. I will tell you that it's not usually a very dramatic photophobia. We'll talk about traumatic iritis, where the photophobia is extremely dramatic. Most of the time there's tearing. The other thing with the photophobia and tearing is a lot of times with the corneal abrasions, once you apply the topical anesthetic, those symptoms kind of go away, and that can clue you into maybe, that there's not something more serious going on. An anesthetic is often needed for an adequate exam. It's very difficult to get a good exam on these patients without numbing them first. And you want to get a good exam because, like I said, you want to evaluate for a foreign body. Fluorescein stain exam with a blue light filter. So what you can see here on the top, this is a fluorescein without a blue light. So it's going to give kind of a light yellow appearance here. And then with the blue light, it gives this very nice green. And you can see how much easier these will be to see with the blue light filter. So the treatment is topical antibiotics. Erythromycin ointment is quite good for this because it provides a barrier as well as providing adequate antibiotic coverage. But if your patients are higher risk, namely contact lens wearers, then you want to cover with a fluoroquinolone because you want to cover for Pseudomonas. You can use topical NSAIDs for pain control, or you can also use just oral NSAIDs. Cycloplegics can also be used for pain control, but they're usually not necessary. If your athlete does wear contacts, you want them to discontinue contact use until they finish their antibiotics and their lesion has fully healed. Topical anesthetics should not be used for pain control, as there's data that they may slow healing. So you don't want to send the athlete home with a tetracaine bottle. And then also eye patch. The use of eye patch is kind of controversial, but there was a fairly recently in the last 5 years or so, there was a pretty big Cochrane review that said for most corneal abrasions, an eye patch is probably not useful, and it may be harmful. It may increase the risk of infection. With these, you want to monitor for improvement. So these respond very quickly, and usually within 24 to 48 hours, the athlete is getting better. If they are not improving fairly quickly, or they're worsening, or for really large lesions, or signs of infection, this is when you would want to refer to your ophthalmologist. So foreign body. So the symptoms of a foreign body are going to be very similar to that of a corneal abrasion. And like I said, they may often occur in conjunction. Foreign bodies can also occur in conjunction with globe ruptures if it's a penetrating foreign body. You can also get conjunctivitis and iritis, so inflammation or infection of the conjunctiva or the iris from these. These can be easily missed. And the classic example is the tarsal plate of the upper lid. So you should always invert the lids for full evaluation. And so you can see here on the right how you invert the lids. You take your standard cotton swab or Q-tip and you put it over there, and then you flip the eyelid over it. Again, in order to do this, you're going to have to use some topical anesthetic for most people. Irrigation should be tried first, and that's the way you should try to remove most foreign bodies off the eye, and that works for most of them. If you are experienced with the Morgan lens used here at the bottom, then you can use that, but you should only use that if you're experienced in its use. If irrigation doesn't work, the next step would be to take a moistened cotton swab and try to run that over the foreign body to remove it. And then if that fails and you have an experienced hand, you can use the tip of an 18 gauge needle, but this obviously should be used with a lot of caution, as you don't want to cause further damage to the eye with your needle. For foreign bodies, the routine use of topical antibiotics is kind of controversial. Most of the studies will say it's probably unnecessary. I will say in my practice, if there's a foreign body, I pretty much cover all of my athletes with topical antibiotics. Unlike oral antibiotics, the risk of, the risk is fairly low. And if you do have an infection with a corneal abrasion, it can have pretty severe consequences. So I think the benefits outweigh the risk in that situation most of the time. But most of the studies will say that it's probably not necessary. So then you have blunt trauma. So on the right here, this is Nika Gumake, who plays for the Los Angeles Sparks. And so you had a very good game and hit some very clutch slots down the stretch of the game. And her teammate, a teammate at the time, Candace Parker, was very excited for her and went up to celebrate with her. And instead of celebrating, actually headbutted her and caused a laceration to her eye here. And you can see her bleeding here. Now, to Agumake's credit, she did not leave the game. She returned to the game and hit 6 clutch free throws down towards the end of the game to take the Sparks to victory. So just goes to show you that our WNBA players are pretty tough when it comes to their injuries. Blunt trauma is the vast majority of sports-related eye injuries. So you want to evaluate for the size of the lesion, the velocity of the object that hit it, and the hardness of the object. All of these are important for determining the severity of the injury. So smaller objects, like objects smaller than the orbit, are more likely to cause an ocular injury, and you should have a much higher suspicion for a globe rupture or globe injury. So that's why sports like baseball, racquetball, that are played with a smaller ball are more likely to cause ocular injuries than a sport like soccer or volleyball, where the force is going to be distributed over the bony prominences of the eye and not the eyeball itself. So with these blunt trauma, you may produce pain, swelling surrounding erythema. We've all seen black eyes before. These are treated symptomatically, and most of the time they're pretty asymptomatic. But you should rule out other conditions first before returning this athlete to play. Subconjunctival hemorrhage. So these are extremely common. Probably most of us have had one before. So they can come from trauma, but they can also come spontaneously from coughing, sneezing, vomiting, those type of things. They're usually asymptomatic. This is usually the one where the athletic trainer gets the call in the middle of the night from the athlete saying that their eyeball's bleeding. And because they looked in the mirror and they saw a picture similar to the one here. If the entire sclera is affected, like we talked about earlier with 365-degree hemorrhage, those are concerned for globe rupture and need further evaluation. Also, you can get what's called a hemorrhagic chemosis. This is the picture here. This is a pretty extreme example. Basically, this is a hematoma in the conjunctiva. So the blood is trapped in the lining of the conjunctiva, and that's something obviously that you want to refer out to get evaluated. With these, the main thing you want to do is assess for visual acuity, make sure that everything else checks out, that they are truly symptomatic, and then these usually spontaneous or resolve on their own in 2 to 3 weeks. Peri-orbital hematoma. So this is a little more than just like your typical black eye. This is a collection of blood around or behind the globe. Most of the time, these are self-limiting, but a larger hematoma can displace the globe. It can increase interocular pressure and expose the cornea, and those larger ones may require referral for drainage. Also, if you have one, you want to have a suspicion for an orbital fracture, and may want to get a CT scan for evaluation for that. So there is a specific type of hemorrhage called a retrobulbar hemorrhage, and this one is quite important to recognize, and because it can have pretty severe consequences. So this is a hemorrhage behind the eye, and the problem is that there's nowhere for the blood to go, and so it can lead to compartment syndrome within the back of within the orbital space, and compress the optic nerve and the ophthalmic artery. There are documents that raise pressure for longer than 60 minutes can lead to permanent vision loss. So this is something you want to have a very high suspicion for. You want to get them somewhere very, very quickly. Usually you're going to see peri-orbital bruising. They will have vision impairment. You will often see proptosis, so the pupil will sit forward, and they will have a relative very afferent pupil deficit. This is more common in athletes with clotting disorders such as thalassemia, sickle cell anemia, or those on anticoagulant therapy. And obviously this requires an emergent referral. So orbital fractures. So we're going to briefly touch on this, but like I said, this will be covered in more detail at the next lecture. In a study from 2010 to 2013, they accounted for 9.5% of all sports-related ocular trauma, so pretty common, usually from blunt trauma with an object such as a ball. The inferior orbital wall is the most commonly affected, and the medial wall, the second most commonly affected. Sometimes you will see in ophthalmos, which is where the eye sits back that we've talked about before, you'll see peri-orbital ecchymosis. They'll have painful external ocular motion. They may have an upward gaze restriction or upward gaze diplopia, especially if the inferior rectus is trapped. And then they can also get a decreased sensation just below the eyelid if you have trapped the branch of the facial nerve there. You want to make sure that you tell the patient to avoid blowing their nose, as you don't want to displace the fracture further. This one needs to be referred to the ED for evaluation with the CT scan. And approximately a third are associated with other significant ocular trauma. So if you have a orbital fracture, then there's 33% of the time there's likely another ocular trauma that needs to be addressed as well. So you can see here in this picture kind of how this happens. So you get a smaller hard object such as a baseball, goes right to the eye and then causes a fracture. This one actually, again, fairly benign looking injury just off a bunt, but it actually did require surgery for this athlete. Okay, so traumatic iritis. So if you have never seen this and you see it the first time, it will scare you. It is very dramatic most of the time. So it is usually caused by blunt trauma, and it accounts for about 20% of all iritis. And so basically what will happen is, for example, the couple athletes that I've seen got hit with a basketball, had severe eye pain, blurry vision, severe photophobia, could barely open their eye because of their sensitivity to light. You can get floaters. Neither of my athletes had floaters, but severe tearing. Both my athletes had kind of decreased visual acuity, but they could still see somewhat. And then often they'll have a sluggish pupil on exam. Now, the thing with this is this in and of itself is not, it looks very dramatic, but it's not that serious of a condition. But the problem is that with these symptoms, it's you can't really distinguish it from other more serious ocular conditions. And really it needs a slit lamp to diagnose. So if you don't have access to that, then you're going to have to refer out to an ophthalmologist to get them. And the classic example is you see what's called a cell and flare, which is cells and protein floating around in the anterior chamber. And that's the classic finding on a slit lamp exam that leads to this diagnosis. Treatment was with cycloplegics, and there's some data that maybe topical corticosteroids can help as well, but you want to make sure that there's no infection before you start topical corticosteroids. So a hyphema. So hyphema is a hemorrhage into the anterior chamber of the eye caused by trauma that shears the blood vessels of the iris. So you see here on this picture here, you can see the blood kind of pooling in the anterior chamber. These patients will have pain, swelling, and they can get either pupillary constriction or dilation. Either one can occur with this. The acute management is a rigid eye shield. So you want to put a hard eye shield on them. They need bed rest with head elevation. Obviously, they need to stop all aspirin and NSAIDs. The use of cycloplegics is very controversial, and so these need to be referred to ophthalmology for full treatment, because the main reason is complications. So they're at high risk for rebleed. It can lead to glaucoma, and unfortunately can lead to particulate accumulation with the anterior chamber, which stains the cornea and can lead with permanent vision problems. So a vitreous hemorrhage. So this is accumulation in the posterior chamber. Obviously, you're going to have to see this on a exam with an ophthalmoscope. The picture here obviously was taken with a camera looking at the retinal camera. It can come from trauma. It can also come from aneurysm rupture. It can come from a retinal tear or detachment. And then it can come from neovascularization with some of our medical problems such as diabetes or high blood pressure, and also is common in patients with sickle cell anemia. This usually presents with floaters or cloudy vision, and it can come anywhere from cloudy vision to severe vision loss. Usually want to address with cold compresses for pain and make sure they stop any blood thinning medication, and these need referral to ophthalmology as well. So a retinal injury or detachment. So these also can be traumatic or spontaneous. So the spontaneous ones, there may be a genetic predisposition to them. So if your athlete has a parent that had a retinal detachment, they may be at higher risk. It's more common in people who are myopic. And it has been reported in endurance athletes. So something to think about in our runners and our marathon runners and endurance athletes. The mechanism in endurance athletes is not completely known, maybe from repetitive microtrauma from jostling from running, but no one really knows the exact mechanism of that. With trauma, it usually occurs by blunt force, which basically leads to a transient increase in intraocular pressure. And this causes separation of the retina from the choroid. This will present with flashes of light, floaters, and the classic curtain in the visual field. So people say that they see a curtain or they see something blocking half their visual field. They can also have decreased peripheral or central vision acuity. There are documents of using point of care ultrasound for diagnosis. So if you're looking at an ultrasound of the eye, this on the left is normal. So you see here, you see your anterior chamber, your vitreous cavity, and then your retina kind of lines the back of the eyeball. You don't really see the retina on the ultrasound, from the back. But on this view, on the right, you see how you've got this line of retina right here that's detached in a space in between. And so that's diagnostic of a retinal detachment. On ophthalmoscope exam, you can see this if you're pretty skilled with the ophthalmoscope. And you can see here how there's fluid under the retina and a retinal detachment, very different from the normal retina here. Obviously, these need emergent referral to ophthalmology because the quicker they're fixed, the more likely, the less likely they are to lead to vision damage. So globe rupture. So this is probably the most important thing to make sure that you don't have in your athlete. So it can occur from blunt trauma, but it can also occur from penetrating trauma, such as a foreign body. So signs and symptoms can be the subconjunctival hemorrhage. Hyphema can be a sign. Loss of anterior chamber depth. So you lose that obliquity to the sphere. So the sphere becomes more of a true sphere and you lose that depth of the anterior chamber. They may have pain with extraocular motion. Most of them will have decreased visual acuity. You may see an irregular or teardrop pupil, as you see on the picture on the top here. You see how the pupil has this irregularity and then teardrop, and then you can see the defect actually on this one right here. And then they can have an afferent pupillary deficit. On the bottom here, obviously you see the iris kind of extruding through this defect in the sclera. These need an immediate hard eye shield and emergent ophthalmology referral. If there is a protruding foreign body, do not try to remove it. Allow the ophthalmologist to remove it. On these patients, you want to avoid any topical anesthetic or fluorescein because both are toxic to the retina. So if you have a defect in the globe and the anesthetic gets into the retina, it can be toxic to the retina. The biggest thing is to avoid pressure to avoid further damage. So if the patient is vomiting or in severe pain, you need to give antiemetics, analgesics to prevent that Valsalva. Also, you should be aware of a condition called sympathetic ophthalmia. So basically, this is bilateral eye inflammation that occurs after a globe rupture. So after a penetrating trauma, it can occur months, it can occur days, even up to months after the injury. And again, it affects both eyes, not just the eye that had the trauma in it. It'll present with changes in accommodation, photophobia, tearing, and floaters. And it needs to be treated with systemic and topical corticosteroids. So something to remember in those athletes. So eyelid injuries and eyelid lacerations. So these may be seen with blunt or penetrating trauma. Often breakage of goggles or glasses can cause these. So if your athlete's wearing eyeglasses and then the glass gets in, cuts the eyelid. Obviously, you want to rule out foreign bodies and globe injuries as they can occur concomitantly. If the wound's superficial and involves less than 25% of the eyelid, a lot of times you can put some stereo strips or Dermavon and they'll heal by secondary attention just fine. Obviously, you want to look out for Iritis, which can lead to corneal ulcers and permanent vision loss, and that can occur with an eyelid laceration or after. So on the bottom left here, you can see this is a laceration that you could repair on your own. This one does not need referral. But if the laceration involves the lid margin, such as the one on the right here, or the lacrimal duct, if it's through and through, or if it involves the medial canthus, those need to be referred out. Also, if you see orbital fat leaking through that needs to be referred, as usually that's indicative of a levator palpebrae muscle injury. And often those patients will have ptosis as well. The time to closure on these is not your typical, we always say lacerations, 12 hours, but really these can be fixed up to 36 hours after and do just fine. So finally, we'll talk about UV exposure. So always something to think about in our athletes. Of course, certain sports such as long distance running, hiking, snow or water sports carry a greater risk. UVB is more damaging to the eye than UVA. Long term, it can cause cataracts. It can cause pterygium, which that's the waxy kind of filmy growth on the eye. You also can cause skin cancer of the lid or the orbit. Photokeratitis, which is inflammation of the cornea due to UV damage, and then it can cause degenerative changes of the cornea. There's also some data that maybe it possibly could be linked to macular degeneration, but that's not completely known. Acute burns of the eye can occur, so you can get a sunburn in your eye just like you can get anywhere else. And these usually present with photophobia and intense pain. And when you do a fluorescein staining, you'll actually see fine, like little punctate lesions all over. And the treatment is usually symptomatic and topical antibiotics to prevent infection. Obviously, you prevent UV exposure with sunglasses or proper sunglass wear. So when we talk about some return to play recommendations, so the eye, when it comes to the eye, return to play considerations are usually pretty easy. So for like a corneal abrasion or foreign body, if there's no functional vision loss, they're minimally symptomatic, they can return to play. Same thing with subconjunctival hemorrhage or a blunt trauma to the orbit or the eyelid. If they have good visual acuity, if they're minimally symptomatic, then they can go back. But most other injuries, they're not going back to play, at least until they're fully evaluated and cleared. So obviously, if you see a hyphema, orbital fracture, retinal injury, globe rupture, those all need to have further evaluation with ophthalmology and should probably be cleared by the ophthalmologist before they return to play. Eyelid lacerations, again, if they're minor and they don't require sutures, or you can suture them up and they have good function and no vision loss, then they can go back. Same thing with UV exposure. So the good thing about eye injuries is almost 90% of all ocular injuries are preventable with eye protection. And so the problem with that is that eyewear is not regulated in many sports at all. So it is regulated in collegiate women's lacrosse and collegiate hockey. But other than that, eyewear is not regulated in any other sport. A little bit last, Willie will kind of discuss the monocular athlete. So you will have athletes that are monocular. So the definition of monocular is you can't correct their vision to better than 20/40. So the eye is 20/40 or worse, even with the best correction. And the reason that that's important is if they were to get ocular trauma to their good eye, then they essentially have vision problems and they're essentially blind. And so it's recommended that all athletes that are monocular wear protective eyewear with all sports. And it is also recommended that they do not participate in boxing or MMA. So this is something that you're picking up on your physical. This is why we do Snellen charts at all our physicals to try to catch these athletes. So in summary, ocular injuries are very common in sports, and they can create a lot of anxiety, as that's not something that a lot of us are all that comfortable with or have seen that many times, but they will occur in sports. So it's important to know how to evaluate them. Most all injuries are minor, but there are some severe injuries and they can have severe problems if they are not addressed appropriately. So it's important to know when to refer out. You want to have the skills and material to do an adequate exam on the sidelines, especially if you're at a high-risk sport. You want to have your friendly ophthalmologist on call that you can get in touch with if you need them. And then it's also important to remember that eye protection can prevent most ocular injuries. So something we can educate our athletes about. So Thank you for your attention. And if you have any questions, I'll be happy to answer them.
Great. Thanks so much, Dr. Robinson. Those are definitely high yield points. I've had just in the last year several ocular injuries covering events, and was definitely on up to date, trying to get a refresher of what I needed to do. But ocular injuries definitely are common in sport, and something all of us need to be up to date on and aware of for sure. So if anyone has questions, put them in the chat. We don't have any questions as of now. I'll give everyone a little bit more time. But as of now, we don't have anything. Speak now or forever hold your peace.
Yeah, it's important to realize that, like everybody has a little bit, this is, I think, something that none of us as primary sports medicine physicians kind of consider ourselves experts on, and so it always creates a little bit of anxiety in everybody. So that's pretty normal. But especially if you cover a high risk sport, like, I became more familiar with these when I started covering basketball more frequently, because, they happen a lot. You catch an eye, you get going up for a rebound, you catch a finger to the eye, things like that. And so becoming more comfortable and knowing like when they really need to go somewhere else. Luckily at a lot of the more professional levels, you have, ophthalmologists, if they're not at the games, they're, regularly, but very on call and accessible. But if you're covering colleges, especially some rural colleges, you got to create those contacts so you have them when you need them.
Yeah. So Nate Nye has a question, wondering about your thoughts on the indications and contraindications of ocular ultrasound. Any practical tips? And is a low frequency probe potentially damaging to the eye?
Yeah, so this is something I came across when I was doing, looking at some of the literature and stuff on this. This is not something I have actually ever done, but it's kind of interesting, especially for retinal detachment, because the couple things I saw, the examples and things that I found in the literature and online, they were pretty impressive. Which I struggle with an ophthalmoscope exam, I think, like most people do, without a proper dilation. And so it's interesting. I think that the main indication is for retinal detachment, and I think that's where you mainly use them from. And I think the big thing is, obviously, if you are worried about like a globe rupture or something, you don't want to be sticking an ultrasound and creating more pressure and causing more damage. So it's not something that I have done, and I wouldn't recommend doing it, of course, unless you have more experience, but it's something I definitely am looking into. I actually polled some of our ophthalmologists to see if they had used it before, but none of them have really used it either.
Great, thanks. So here's another question from Neil Patel. What are some good techniques and tips to getting athletes comfortable to relax for an eye exam?
Yeah, so that's a big one. And I think it's important to remember that, some of it is the symptoms themselves, the pain, the tearing, but a lot of it's anxiety. They just got poked in the eye. When you get poked in the eye, you're never able to see very well initially. It takes a while for your vision. And so it can be very anxiety provoking for a lot of athletes. So just taking them somewhere, usually taking somewhere low light, so there's not a lot of bright lights. So like, in a basketball arena, I like to get them off, out of the arena, back into the area behind the stands where the lights are a little low. Then you can usually get them to kind of relax, open their eye, and evaluate. And then once you've kind of evaluated, you don't think there's a globe rupture or anything like that, then I'm pretty quick to use the topical anesthetic so that I can actually get a really good exam. And then once you put a little tetracaine on there, then it's really easy to get a good exam.
Yeah, I think that's big. There was one time for sure this year that I really wished I had some tetracaine and didn't have any with me, and it really limited what I was able to do. So that is, if there's a way for you to have a little bit of that in your bag, especially if you're covering something higher risk like basketball, then definitely, have some tetracaine handy, because it'd be really helpful and help to ease some of the anxiety for sure.
Yeah. And kind of just another pearl. I had a fellow one time call me from the sidelines because they were trying to do the fluorescein exam, and they're like, I can't do it. I can't get the athlete to do it. And they had numbed them up first. So I would not attempt a fluorescein exam without numbing first. Don't stick that fluorescein paper in somebody's eye without them numb first.
Yeah, for sure. All right, so no other questions. So we'll wrap it up. Thanks again. Great talk. Very high yield topics for a sideline sports medicine doc for sure. Everyone be just a reminder for our talk next week, Wednesday night, 8:30 is kind of our standard time. Then again, on December 15th for the role of the head team physician panel with great speakers there too. So thanks again for the great talk, Dr. Robinson, and we'll see everyone next week.
Thanks, guys. Thanks for coming. Happy holidays.